Cerebral palsy is primarily a neuromotor disorder that affects the development of movement, muscle tone, and posture, causing activity limitation that are attributed to non-progressive disturbances that occur in the developing of the fetus or immature brain. Although prematurity and low birth weight are main risk factors for developing cerebral palsy, multiple factors are associated with the risks. For this particular patient, gestational premature birth is the primary reason, and she did have lack of oxygen to her brain after birth, which is also a high risk factor for the development of cerebral palsy. There are typographic classifications of the disease, quadriplegic being the most severe, including all four limbs, and this primarily comes from the oxygen deprivation. Children with cerebral palsy often have common challenges regarding growth, mobility, dysphagia, muscle tone, alternative complementary medicine, so many drug side effects, and nutrient interactions, issues with feeding, normally resulting in enteral and parenteral nutrition. They have GI problems, orthopedic, and pulmonary status issues. Cerebral palsy is primarily a neuromotor disorder that affects the. Our patient is a 10-year-old female with cerebral palsy who has level 3 gross motor function classification. She is 4'2" and coming in for her biannual assessment and baclofen pump refill. The baclofen pump is a programmable battery-powered medical device that stores and delivers prescribed medication that helps reduce severity of plasticity within cerebral palsy patients. She's Caucasian and the socioeconomic status is not disclosed. A primary concern of the mother is that her weight has recently gone down and she is appearing more thin. She had also fallen a couple days prior on her hip. The patient was born premature at 32 weeks with a birth weight of 2 pounds and 6 ounces, diagnosed with cerebral palsy at 10 months. Her medical history is composed of spastic quadriplegic cerebral palsy, prematurity, developmental delay, seizures, speech difficulties, GERD, and constipation, with a surgical history of the ITB pump insertion back in 2003 and over the past 4 years having lower limb surgeries. The patient is in 5th grade. She speaks English and she's a student. Her household members are her father, mother, and her younger brother who's 4. Her religious affiliation is the Seventh-day Adventist, and she's Caucasian. She lives at home and does attend school regularly, and she does well. She has several friends, and she also has access to a speech therapist who helps her to eat lunch, an occupational therapist, and a physical therapist. Communication is frustrating to her due to her weakened and damaged voice box causing the slur of words. As for family history, the mother has hypertension and IBS, and the father has kidney stones. Her current medications are polyethylene glycol for constipation, lasoprostol for GERD, baclofen for the muscle spasm, Filatin for the control of seizures, and then a pediatric gummy just to make sure that she's getting in the vitamins she needs. Many medications the patient did not respond sufficiently, limiting her mobility, but with the baclofen, it has increased her mobility, allowing her to spend more time outside of her wheelchair using her crutches. However, there are still cognitive limitations and oral motor dysfunctions. The patient's diet is within the realm of vegetarian and advanced mechanically soft, and her family members also follow a vegetarian diet, not consuming meat, poultry, and fish. The patient dislikes most sweets, and she is a very overall picky eater, the mother states, but she eats fairly consistent portions and sizes at regular times during the day. OF does feed herself, and it normally takes her around an hour to eat a meal and 30 minutes to eat a snack. And when asked, the patient did respond she would probably be able to eat more if she was given more time to do so. Evaluating the diet recall, the calorie intake is just shy of 1,000 calories. Prior to this consult, she had met with an RD in an outpatient clinic and when she was hospitalized. In individuals with CP, weight does not reflect the typical distribution of body fat and muscle. Therefore, calculating body mass index is not useful for estimating appropriate weight for height. When plotting an individual up to the age of 20 on a CDC growth chart, the goal is to have an appropriate growth velocity for the child to follow their growth curve, even when the measurements are consistently below the 5th percentile. Therefore, it's not recommended to use a disability-specific growth chart for cerebral palsy patients. As you can see, OF does fall even below the 5th percentile on the growth chart plotting. With her current weight being 51 pounds and her ideal body weight being 100 pounds, she comes in at 51% of her ideal body weight, and she does have a body mass index of 13.6. The tricep skin fold is also a useful tool and a validated, reliable screening for this population. Children with CP present with an unstimulated salivary flow rate, which characterized as an impaired hydration status, increasing the chances of dehydration. The blood urea nitrogen test, measuring the nitrogen in your blood that comes from the product waste of urea, tells how well kidneys are working. Looking at the BUN for this patient's labs, it's high, and in comparison with the creatinine to create the BN to creatinine ratio, this can be indicative of dehydration. Her alkali phosphatase is high, indicating high bone turnover, and this is normally associated with anticonvulsive therapy, which is the medication she takes for her seizures. Alkaline phosphatase levels that are elevated are also essential markers of the diagnosis of vitamin D deficiency, which explains why her vitamin D levels are so low. Reports of the nutrition-focused physical exam show no acute distress at this time. There's dry mucosal membranes, bruising of the left hip with no swelling but a rate of pain, hypertonia, which is a hypermetabolic state due to mild to moderate contractions of the upper and lower limbs based on her condition. Skin appears to be dry, pale, and have normal turgor. Respiratory is normal without cracking or wheezing sounds. Abdomen is soft, non-tender, non-distressed, and there is the ITB pump in the lower left abdomen without swelling. Based on the hypertonia and weight loss, this is another indication caloric needs need to increase, as well as looking at the skin, which is pale and dry, alongside with the BUN, is a further indication of dehydration, calling for a need of an increased fluid intake. The calorie needs for a pediatric CP patient, the age of 10, varies in between 14 and 11 kcals per centimeter dependent on activity level. Our patient is primarily in the wheelchair. However, she does use crutches, moving between small distances. Therefore, I used 12 kcals per centimeter to get 1,524 calories per day. Regarding protein calculations, ideal body weight was used for this calculation, providing 43.2 grams per day. As for fluid needs, this is specific for CP patients. Greater than 20 kilograms requires 15 milliliters plus 20 milliliters per each kilogram above 20. Therefore, the fluid needs are 1,560 milliliters per day. The diagnostic statements for this patient are as follows. Vitamin D deficiency related to anticoagulant therapy, increasing bone turnover as evidenced by alkaline phosphate elevation and low vitamin D levels present in lab values. Increased nutritional needs related to hypermetabolic state due to hypertonia as evidenced by recent weight loss. Dehydration related to inadequate fluid intake as evidenced by elevated BUN lab values and dry skin. Recommended nutrition interventions for this patient are to decrease energy expenditure when eating by possibly allowing someone else to feed the patient rather than her overexerting herself 3 to 5 times during the day. If the intervention is not applicable due to patient's inacceptance, reassess protein and caloric needs. The second intervention is to increase fluid intake by 500 milliliters. Third intervention, increase oral intake by 500 calories. And then fourth, recommend a vitamin D supplement twice a day. Recommended nutrition interventions for this patient. Patient's follow-up will be in 2 weeks. The point of care intervention regarding education will be focusing on the importance of the vitamin D supplementation, the increasing of calorically dense foods that also meet her mechanically soft diet through incorporating the listed options such as avocado, olive oil, which easily increase calories. Though the patient does have barriers to learning due to cognitive limitation, the education will be veered more towards her parents, who will relay information onto caretakers at school and implement at home, hopefully. Materials used will be handouts, and expected outcome is for their understanding and importance of change needed. Patients follow monitoring and evaluations that will be done are specific to medication and education. Regarding medication, monitoring the intake of vitamin D supplementation through recall of medication list and checking lab values will be done. Regarding education, that will also be monitored through diet recall and assessing the patient's weight.